Hi, my name is Peter Yang, and I'm an assistant professor of pediatric neurosurgery at UTHealth Houston and Children's Memorial Hermann Hospital. Today, we'll provide an introductory overview of spina bifida, a congenital condition that requires specialized surgical management throughout a patient's life. We will start by discussing some embryology and historical management of spina bifida. Then we will discuss closure strategies in the modern era and the need for comprehensive care of these patients. Spina bifida is a congenital spinal malformation with a wide spectrum of presentations. Spina bifida results when the caudal or posterior neural pore fails to close into a tube during primary neurulation in the third to fourth week of gestation. As a result, the spinal bony elements, usually in the lumbosacral spine, fail to form a complete arch, resulting in a split or bifid spine. The most severe type is myelomeningocele, the primary focus of this talk, which results from a herniation of neural tissue and the covering membrane of the neural tissue called the meninges. Milder types include meningocele, which is a fluid-filled sac without neural tissues and is usually skin-covered. Spina bifida occulta is the least obvious form, which can be associated with a tuft of hair or birthmark or other skin finding and result in spinal cord tethering. The diagnosis of spina bifida occulta is usually made with an MRI, while the other two are obvious upon inspection. And if there is an entity that defined what it means to be a pediatric neurosurgeon, it's the myelomeningocele, the most severe form of spina bifida. Myelomeningocele is an anomaly that carries significant morbidity and mortality for patients from an early fetal development stage from birth to childhood and adulthood, which includes infection, hydrocephalus, paraparesis, bowel and bladder dysfunction, and tethered cord. Because myelomeningocele is associated with pathology throughout the entire neural axis, it requires a truly holistic approach into its management. Today, I'll share some historical perspectives into what used to be an almost uniformly fatal disease and talk about a few paradigm shifts in recent decades to improve the prevention, diagnosis, and treatment of myelomeningocele. Descriptions of spina bifida date back thousands of years. For example, terracotta figures from Mexico circa 200 AD reveal classic findings for a child or adult with spinal dysraphism. There's kyphosis of the lumbar spine with forward posture and hands resting on the knees. It was not until the late 17th century when the term spina bifida was first coined by the anatomist Nikolai Tulp. On the right is one of the first printed illustrations of spina bifida, which was based on a patient with open spinal dysraphism and hydrocephalus, whom Tulp attempted to repair. This child unfortunately died due to sepsis shortly after surgery. Over the next several hundred years, a number of anatomy textbooks were published that describe the association of spina bifida with hydrocephalus, tonsillar ectopia, paraplegia, urinary and bowel incontinence, and also describe the often unsuccessful treatment of spina bifida, including injection techniques, ligation, and amputation of the fluid sac. It wasn't until the widespread adoption of antiseptic techniques in the late 19th and early 20th centuries that modern multi-layered closure techniques were developed. In the 1940s, myelomeningocele closure was recommended to be delayed until 18 months of age to fully assess neurological and cognitive abilities. In modern times, the timing of myelomeningocele closure has moved earlier and earlier from early postnatal closure to prenatal or fetal closure. A paradigm shift happened in the 1950s with the invention of the Spitz-Holter shunt valve in Philadelphia. In 1955, Casey Holter was a baby born with spina bifida who underwent surgical repair and subsequently developed hydrocephalus and meningitis requiring frequent ventricular taps. Casey's father, John Holter, was a machinist who grew frustrated with the futile insertions of shunts at that time, which were made of polyethylene tubing. So Holter, in his garage, created a one-way valve accompanied by silicon tubing, which was found to be more biologically inert. This was inserted into another child first and then into Casey as a ventriculo-atrial shunt. This had to be revised into a ventriculo-peritoneal shunt, which functioned for almost 3 years. The one-way Spitz-Holter valve dramatically changed the survival of patients with spina bifida from 9% survival at age 10 to 86% survival at age 16 after 1958, with 50% of patients with normal intellect. Holter went on to create valves with different opening pressures, and the modern-day shunt was inspired by a spina bifida patient. Folic acid deficiency during pregnancy had been found to be associated with neural tube defects, and its fortification of enriched grain products has been mandatory in the US since 1998. The CDC today estimates that 1,300 NTDs are prevented each year with a cost savings of $600 million per year. The FDA recommends folic acid for women of childbearing age and women planning to become pregnant to take at least 0.4 milligrams per day from at least 3 months before conception and continued for the first 12 weeks of pregnancy. Women who have already had a baby with spina bifida or other type of neural tube defect should take a higher dose, such as 4 milligrams to 5 milligrams per day. So the technique and timing of closure has been developed over the years to reduce the risk of infection, which is its primary purpose. Over the years, it's been found that early closure within 72 hours also impacts neurogenic bladder prognosis. The standard of care today for postnatal mild meningocele closure is to perform the closure within the first 48 hours of life. On the right is a classic example of a mild meningocele that we close within the first day of life. In the cartoon is a cross-section showing the neural tissue called the placode that is attached to membrane that keeps CSF in. During surgery, the sac is opened and the placode is carefully released from the surrounding tissues and brought towards the small canal. The placode can be rolled or sutured into a tube to reapproximate the pia. After this, the dura is dissected off the lateral tissues and closed in a watertight fashion with or without a patch. After this, the soft tissues are closed, followed by final skin closure. Large defects may require rotational or myocutaneous flap. Postoperatively, the incision is offloaded such that the patient is positioned flat prone or side to side until the skin is healed. The exposure to the placode to the amniotic fluid is thought to worsen neurological function. Therefore, surgeons in the 1990s pioneered a fetal surgery for the prenatal closure of antenatally diagnosed mild meningocele, which makes use of a hysterotomy or an opening in the uterus to expose the fetus. The management of mild meningocele trial was a pivotal trial that began in 2003, which randomized 91 patients for fetal repair and 92 patients for postnatal repair. An interim analysis conducted in December 2010 showed a statistically significant benefit to the surgery and closed the trial. The trial demonstrated that outcomes after prenatal spina bifida treatment are improved to the degree that the benefits of surgery typically outweigh the maternal risks. Specifically, the study found that those who underwent fetal repair were half as likely to require a ventricular shunt compared to postnatal closure. Chiari malformation was less common, and standardized test scores for motor skills were superior in the fetal surgery group. Twice as many children who had fetal closure were walking independently at 30 months as compared to the postnatal surgery group. So based on these outcomes, fetal repair of spina bifida is now considered a standard of care at some fetal centers. There have been several follow-up studies of the MOMS trial of the same patients when reaching school age. Besides confirming reduced shunt rates and better motor outcome, parents of children who had prenatal closure had a higher mean quality of life and a lower mean family impact scores. They're also more competent with self-care and were more commonly community ambulators. In 2015, a subgroup analysis of fetal ventricular size and shunt rates found that ventricular diameter of 15 millimeters or greater did not have decrease in shunt rates, which remains at 80%, and has been an important variable used in prenatal counseling today. While the results of the MOMS trial were encouraging, the inclusion-exclusion criteria were quite stringent, and there was a known risk to the mother of performing fetal surgery via hysterotomy. These risks include membrane separation, placental abruption, spontaneous rupture of membranes, and spontaneous labor. Fetoscopic surgery is a newer and less invasive technique which has been developed to mitigate risk to mom while still providing the same benefits to the fetus. The access to the fetus is performed through laparoscopic instruments via several small incisions in the uterus rather than a single large incision. The advantages of fetoscopic surgery are that there is an opportunity for vaginal delivery in current and future pregnancies, unlike the open hysterotomy approach, which requires a C-section, which carries its own risk to subsequent and current pregnancies. There's also a reduced risk of uterine rupture and typically a longer gestational period with fetoscopic repair. There appears to be a slightly higher rate of cord tethering with fetoscopic closure. At UTHealth Houston, we have a comprehensive multidisciplinary fetal center that includes consultation regarding fetoscopic repair. Our surgery is performing a trial to investigate a specific closure technique currently. After closure, the patient with mild meningocele is confronted with sequential challenges as they grow up: hydrocephalus, Chiari, syringomyelia, and tethered cord. First in time and importance is hydrocephalus. To monitor this, serial head circumference measurements, fontanelle exams, and cranial ultrasounds are performed while the baby is still in the NICU. The next important thing to understand is that spina bifida is a static anatomical disease, meaning that patients after the perinatal period do not naturally have progressive neurological symptoms. That means that a patient with new bladder incontinence, leg weakness, decreased cognition, and other neurological findings should indicate a new or recurrent clinical problem. This means that a patient with a CSF leak after meningeal myelocele closure should undergo a hydrocephalus or shunt workup first. In fact, in recent years, even Chiari symptoms can be treated with shunt exploration and revision, although each case must be individualized. Recently, there has been an increased interest in treating hydrocephalus without a shunt via an endoscopic third ventriculostomy with or without a cord plexus cauterization. In the modern era, many patients with mild meningocele survive into adolescence and beyond, with the majority with normal IQ, ability to ambulate, and live with minimal assistance. This is in stark contrast to the prognosis of these patients even just 20 to 30 years ago. These advancements are thanks to basic scientists, engineers, clinicians, clinical trialists, and public health officials. Today, these advancements give hope to patients who can live a relatively normal life for what was uniformly a fatal disease. With longer life expectancy, however, are challenges that come with management of chronic disease, in this case, multiple shunt malfunctions and recurrent tethered cord. Ongoing challenges are the coordinated care of these patients who have multi-system abnormalities and the prevention of neural tube defects on a global scale. Thank you very much for your attention.